To start us off this morning, though, we actually have the Honourable Catherine King, who's the Australian Shadow Minister for Health and Medicare, who's actually going to just kick us off on day 2 with some thoughts from her perspective in the Australian federal health space. Catherine.
Thanks very much for that introduction, and can I start by acknowledging the traditional custodians of the land on which we gather and pay my respects to their elders past, present and emerging. To the President of the International Hospitals Federation, to the CEO of the Australian Healthcare and Hospital Association, Alison Verhoeven, who I understand hit the dance floor last night, and it's her birthday today as well, so happy birthday to you. To Chair Deborah Cole, who's also one of my constituents in the state of Victoria. To Queensland Health representatives, thank you for your terrific role in organising this Congress, and to all of you, the delegates who've come from across the nation and from all over the world to come and talk about how best to provide hospital care to your citizens. Welcome this morning. I hope you enjoyed last night and are ready for a terrific day today. Well, the last time that Australia hosted this Congress was more than 20 years ago in 1997. And at that time, Australia was deeply mired in the hospital wars, a seemingly endless battle between the Commonwealth and state governments about how to fund our public hospitals. Australia's public hospitals were then, and still are today, owned and operated by states and territories. And of course, up until the Second World War, they had sole responsibility for funding them. That of course changed in 1945 when the Commonwealth took over the power to tax income, giving it far greater revenue-raising powers. From then on, the Commonwealth's contributions to state hospital budgets were negotiated every 5 years with 5-yearly agreements. These negotiations would almost invariably generate tension and acrimony between the Commonwealth and the states, as both sides accused each other of falling short, failing to pay their fair share, falling short, and of cost shifting. By the late 1990s, the last time Australia hosted this event, it was painfully obvious that something needed to change. Negotiations in 1998 and in 2003 were particularly rancorous. That's why in 2007, the Labor Party, the party that I am a member of, campaigned and came to power, promising to try and end the blame game. It proved pretty difficult. In 2011, our National Reform Agreement sought to replace the ad hocery of the 5-yearly deals with the long-term certainty of an activity-based funding formula that rewarded efficiency. It was a historic change for Australia, and frankly, it was the crucial first step in remaking our hospital funding system into the 21st century. It was a reform that, unfortunately, the current government tried to unpick in 2014 when it announced that it was going to scrap activity-based funding and revert to the previous funding system. Thankfully, they came to their senses and reversed that, meaning we now have what appears to be a bipartisan commitment to activity-based funding in this country. Although I do note that the current Conservative government has decided to pick a fight over retrospective funding for the states, and I think you might have seen some of that at play yesterday, most publicly with Victoria and Queensland, which does have some potential to derail this. Indeed, the two major political parties in this country still have some stark differences when it comes to hospital funding levels. We believe that the Commonwealth should fund an equal 50% of the efficient price growth, as we agreed to do back in 2011. The Conservatives, on the other hand, have committed to funding just 45%, meaning they're delivering billions of dollars less and, in our view, ensuring that that blame game continues. It's not my intention today to dwell on this partisan fight. There'll be plenty of time for that in the coming months as we approach the next federal election. But what I do want to say is that our hospitals, as we know it, are still facing ever-rising demand and increasing acuity, though there's still a need for the Commonwealth to pay its fair share. There's no way around it. Raw investment still matters. And when the Commonwealth isn't paying its fair share, it undermines its ability to lead a genuine reform process. The Commonwealth can hardly insist on conditions in its funding to the states if the states believe that funding is inadequate. But enough of politics. What should Australia's hospital reform agenda actually look like? How do we build on the foundations we've built over the last 10 years to deliver better quality care? Activity-based funding has already made our public hospitals more efficient. That's a good thing because it does allow more services to be provided within the same budgets. But there is, of course, still more to be done here. Health resource waste within the hospital system, particularly as the Chief Medical Officer of my own local hospital said to me a couple of days ago, in the context of the perfect storm of ever-increasing demand for increasingly expensive services in an environment of budget constraint, will remain a very important area of work. But we also need to work with the states and territories to make our hospitals more effective. Activity-based funding gives us a platform to do it, but we still need to drive these changes. One of the problems, of course, is that the current system is that we don't pay hospitals for what they don't do. They've got no financial incentive to prevent admissions and limited incentives to prevent readmissions. We need to create those incentives. 10 years ago, Australia's Health and Hospital Reform Commission said, "We recommend that there be financial incentives to reward good performance in outcomes and timeliness of care." So this isn't a new idea. It simply comes down to whether there is political will to deliver these sorts of changes. Penalising poor safety is one thing, but we also need to think about how we reward quality care. To achieve the best possible levels of hospital care, we need a carrot as well, sometimes as a stick. Ultimately, I want a system in which we focus on and invest more in prevention and primary care so that everyone who can avoid hospital admissions does so at the time. And I believe we need to find ways to encourage hospitals to actively be part of that process rather than removed from it. I'd like to see hospitals actually investing some of their resources or being able to invest those resources into preventative health care in their communities in partnership. Better integration will be key to achieving this. Clinical care in this country, and in many of yours as well, I'm sure, remains too fragmented. All too often, GPs, specialists, hospitals and outpatient services still operate in silos. We need better horizontal and vertical integration between doctors, specialists, between other specialists, and between primary and specialty care, and between hospitals, primary care and outpatients. This is particularly important to address the growing issue of chronic disease. So yes, we need to find opportunities for hospitals to work outside their four walls. And today's sub-theme, from four walls to their neighbourhoods, is by no means a new concept. It's a simple acknowledgement of the obvious, that an episode of care extends well beyond the hospital walls, often involving GPs, specialists, pathologists and pharmacists and other allied health professionals. And the better we integrate those elements, the better the care will ultimately be. Before I conclude, I just want to briefly talk about the role of private hospitals in the Australian healthcare system. In Australia, private hospitals play an important role in the provision of non-urgent care, particularly elective surgery. And while the political fight of recent years has of course been firmly focused on the public system, which is entirely appropriate, it's still important to acknowledge that private hospitals account for nearly half of all hospitals in this country. And it's important to note too that the Commonwealth, and by extension all taxpayers, are substantial financial stakeholders in private hospitals, most notably through our sizeable subsidies to private health insurance premiums. In general, private hospitals in Australia are experiencing a drop in demand. That's being driven by a number of factors: decline in the number of people holding private health insurance, increasing concern over costs of utilising private health insurance, and increasing gap payments when it's used. Improvements in the amenity of many large public hospitals and offerings for private patients within the public hospital system, as well as the view that private patients are a growing source of additional revenue for public hospitals in a constrained budgetary environment. The challenge, of course, for governments is that within the private hospital system, the policy levers available to drive the same sort of efficiencies and effectiveness measures being pursued in the public system are weak or simply not available. Governments to date have either been ignoring the problem or tackling it in a piecemeal way by focusing on parts of the problem in isolation. But given the importance of the private hospital system in the overall mix here in Australia, Labor has said that the private hospital system must be part of the hospital reform conversation going forward. It's why private hospitals and how they interact with our public hospitals will be an element of the Root and Branch Productivity Commission inquiry into private health insurance that we announced earlier this year. I'm also considering the establishment of a permanent Australian healthcare, I'm not quite sure about the word reform, but perhaps innovation commission. This commission would have a broad mandate to continuously monitor and improve our entire hospital and healthcare system. It would focus on developing, trialling and evaluating new models of care that seek to improve quality and safety and, where possible, bring down costs. Such a commission, in the upcoming election, which is due in the next 6 to 7 months, wouldn't win us a lot of votes, but it could be one way to break out of the short-termism that can afflict policy making in this country, and I'm guessing in many of the others that are here as well. So Australia has made some progress since we last hosted this event, but clearly there is much more to be done. That's why events like this are so important. Many of us are grappling with the same problems. By working together, by exchanging ideas, hopefully we can all move closer to solutions. I wish you well in the deliberations today. Thank you.